Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Hello, May is Stroke Month, and I literally just told the docs, hey, we're just here to have a good time and give information, because May being Stroke Month, it's not a purpose to celebrate, but it absolutely is a reason for us to get together and talk about some of the things that we may not know about strokes, and specifically about caring for our brain, and that's why we're here this evening. During this hour, we have experts talking about strokes and all kinds of people, not just those who are at high risk. Because if you're not at high risk of a stroke and you're having a stroke, do you think you're having a stroke? We don't know. That's what we're going to talk about this evening. There are strategies, there are treatments, and there are all kinds of ways to save lives. The biggest thing we're going to talk about tonight is time. As you know, this is a live show, so think of some questions that you want to ask about this evening. You can call us at 881-0013. We are also streaming live on YouTube, so if you have to disappear from your TV, or if you want to call somebody and say, hey, there's a show about strokes, I want you to watch this, have them go to youtube.com and then just search El Paso Physician Live, and they can get to this show right now. We're streaming it live, and they can also ask their questions. Again, that number to call is 915-881-0013. This program is underwritten by Tenet, the Hospitals of Providence, and we also want to thank the Texas Tech Paulo Foster School of Medicine for providing our very own Saeed Zaidi tonight, and he is going to be sending questions my way via my telephone. So I just told the docs on the air that when I'm looking at my phone, I'm not ignoring you, I'm just looking at questions from the audience. And I also want to do a big high five to the El Paso County Medical Society, who's been doing this show now for 25 years. This is the 25th anniversary, and good for them. Thank you for joining us. I'm Catherine Berg, and you're watching the El Paso Physician. It's interesting because I'll have some of these doctors on the show, and yeah, they're doctors, but I've known them for 20 years. We've been doing this show for 20 years. You know, he talks about farts, and he talks about diarrhea, and he talks about all kinds of things that nobody wants to talk about. And that's what's great about the show, because you get to hear those things on the show and go, I'm not the only one. It's great. It's the El Paso Physician. So this is kind of a unique show. We usually have doctors on the show, and every now and again we have another specialist, and we have a firefighter here with us this evening, and his last name is Peebles, and I was joking with him right when we got on the air, before we got on the air, that I've only known one other person that has your last name and the spelling of your name. But we have with us this evening Dr. Alvarez, who is directly to my right, and she is internal medicine. Then we have Captain Peebles, who is with the El Paso Fire Department. And then we have Dr. Eze, who is a neurologist. So all three really fantastic disciplines to talk about stroke and brain health in general. And it's nice to have a first responder here, because we're going to ask you all kinds of questions of what people ask you, because sometimes that's how we're educated. It's like, what are people asking you, and what is it that we're trying to figure out? So Dr. Alvarez, I'm going to start with you. And if you don't mind telling the audience at home, you're a hospitalist, you're an internist, general studies, but not so much, all day, every day, what it is that you do is important to the audience at home. Like, what is it that you can say to them? It's like, this is what I do, and this is why I am speaking about stroke this evening.
So basically, I'm in the hospital the whole day, 7 to 7. And I attend to patients that come obviously sick, and I do the full assessment, and there's a special protocol for two other things, stroke one, and the other one is heart, because we are a center for both, and so we focus on protocols that if we have a patient with stroke, we know that we're getting it, and then we follow a protocol. So it comes from treating the patient, and then the education afterwards.
And that makes perfect sense. And I know that I kind of put you on the spot because we were all talking right before we went on the air. And usually I let people know, hey, I'm going to ask what you do all day, every day. And I didn't ask you that. So now both of you get to have a little jump on this. So Captain Peebles, and again, not being a medical doctor, but being in this field, and what you do all day, every day, I'd imagine is very different every single day. But just to give the audience a brief description of what you do all day, every day. Fire department, people think, oh, you put out fires, but there's a lot more to it.
Absolutely, Catherine, and thank you for that question. So the El Paso Fire Department, we respond to numerous stroke calls, probably at least 3 to 4 on a day-to-day basis. So we have protocols that allow us to rapidly try to assess and triage these individuals. Again, time is the essence when it comes to stroke. That's probably going to hear that as a common theme throughout the panel here. So time is of essence, and we have protocols that are in place that allow from that first 911 call out from the public, from the community, for our communication staff to automatically start triaging and identifying whether or not they're going to need that rapid response. Simultaneously, by doing that, as these crews are dispatched to those crews, the technology that we have from the communication systems are already starting to transmit that information to our first responding units. Our first responding units typically come equipped with ALS interventions, paramedics. We also have first responder pumpers that are equipped with paramedics and who can provide ALS intervention and get that critical assessment done first. We use the Los Angeles Pre-Hospital Stroke Scale system. The instant our teams get on scene, and that is a positive lab score, we're automatically calling for the mobile stroke unit, which the fire department has a collaboration with University Medical Center. So once that is activated, we're able to get that care quicker because that dispatch is very precise. So we've been able to triage that out, parse out those questions that will require that rapid intervention so that assessment can get done and the patient transported.
And I'd imagine during this evening there's going to be a lot of questions on what first do we see, what are we looking for, and what is it that people are telling you that have had a stroke? Because there is such a myriad of things that people are describing to you. So I'm going to ask you some of those very specifically there. I have a feeling that from the audience, all of that is going to come in as well.
Yes, ma'am.
Dr. Eze, as the neurologist, this is like bare bones research brain lady, right, at this point. What you do all day, every day, we're talking about strokes this evening, yes, but neurology encompasses so many different things. What is it that you focus on during the day?
So during the day, I see patients both in the hospitals and in my clinic, patients with varying neurologic diseases. So we have patients with dementia. Stroke is a very common neurologic disease. So I spend a good amount of time both in the hospital and in the clinic taking care of patients who have stroke. In the hospital, it's the job of the neurologist in conjunction with the hospitalists and other specialists like the cardiologists, and of course the emergency medicine physician, first of all, to determine if a patient who comes in with an acute neurologic condition has a stroke. Do they have a stroke? If they have a stroke, it's also our job to kind of make a hypothesis. Where is the stroke? Would this patient be amenable to the acute treatment protocols that we have for stroke? Now, if the patient is amenable to that, we would give the directions to give them what we call IVTPA. At that point, we're also assessing to see if it's a big vessel that is involved or a small vessel that is involved, because the protocols are different for both. We also institute evaluation protocols. We order tests that would help us determine how bad the patient is, where the patient should go to. Should the patient go to the cath lab immediately? Should the patient be taken to the ICU? What kind of stroke it is?
Right.
Is it a hemorrhagic stroke? Is it an ischemic stroke? We make all those determinations there and then. And then while the patient is in the hospital, we determine how bad the patient is, what interventions we can put in place to help them. We also try to figure out what are the risk factors, what made this patient have the stroke in the first place. Because you'd find out that 1/4 of people who have strokes have had strokes in the past. So we want to reduce that number. Now, occasionally, I follow a patient through all the way through their hospital stay into the rehabilitation stay. So in some hospitals, for instance, at the Sierra Hospital, you also have a rehab, a neuro rehab, where the patients go to get stronger and better so that they can get home. So I follow them there to and make suggestions. Sometimes you would see a patient who has had a stroke who is depressed or who has other problems that we take care of there and then. Then I also see stroke patients after they've been discharged from the hospital, kind of addressing the problems. Are there leftover problems or leftover interventions that we haven't addressed while they were in the hospital?
Okay,
So
I need to stop you from talking. You know why? Because the whole show's over now.
no, I don't think so.
You've answered how many pieces of paper here? I have like 18 pieces of paper,
Very thorough,
and you've answered
very
every
thorough,
single
very
one
thorough,
of them.
very thorough.
No, seriously, I am so excited to have your area of expertise here and to have your knowledge. Because I like trying to going from ischemic, so we're going to talk about hemorrhagic and ischemic, but what I would like to do is quickly ask you, Dr. Eze, before we go back to the hospitalist, because this is where everything kind of comes in. When you're having a stroke, you need to get in immediately, it's fast. When you were talking about an acute neurological condition, if it's not a stroke, what would that be? Or are you talking basically about strokes? I know that's a loaded question.
No. So
Okay.
oftentimes a patient comes into the hospital with their face drooped.
Right.
It could be Bell's palsy. It's not a stroke. The patient
Gotcha.
could come into the emergency room and they have a bad headache and one side is weak. We know this patient from multiple hospital admissions. The patient is a migrainer. That may be a hemiplegic migraine. A patient could come into the hospital in the emergency room and has the arm jerking. Okay, is that a seizure? Is the patient's side weak? Or the family says, oh, before the side was weak, they had some twitching of their arm that lasted 10 minutes. Is the weakness due to a stroke, or is it due to what we call Todd's palsy that happens post-seizure? The patient could have passed out. Okay, is this a fainting spell or syncope, or could it be due to? So those are the things we think about as we're trying to assess the patient in the emergency room.
And I would love to have just a separate show, and I say this a lot, just on seizures and syncope, because I think those are so common and misinterpreted. So I'm glad that we're bringing those up during this program tonight. What I'd like to do is, Dr. Alvarez, as the internist, as the hospitalist, and Captain Peoples, kind of listen to this because I might just throw you into some of these questions at the same time. When EMS is coming to you, when Captain Peoples and his team is bringing someone to the hospitalist, and there is, you know what, these are some of the symptoms, and you are trying to assess, is this an ischemic stroke? Let's first define those two. Actually, that's probably the big thing. Let's define what an ischemic stroke is and what a hemorrhagic stroke is, because those are the two biggies, and I know there's other kind of little ones that we talk about, but let's define those two first, so that as we're going through, people in the audience know what we're talking about.
So for the ischemic stroke, we have two types. We all hear embolic, which is coming, a thrombus coming from elsewhere, and also
Like the blood clot is coming from elsewhere, okay.
and a thrombotic stroke that it's coming, it's forming a plaque, let's say cholesterol. And so that's ischemic. And then hemorrhagic, you can have an aneurysm that ruptured, and so that causes a hemorrhagic stroke.
So that's basically a brain bleed, just for those who are not familiar with the wording. So it's when the bleeding happens in the brain
Yes,
versus
correct.
the blocking happening in the brain, correct? Okay.
Yes. And we also have, I have to include the TIA, the transient ischemic attack, just because it's now included in the definition of stroke. And that it's same as the ischemic stroke, but the blood flow resumes, so you know, it's not really complete.
So pardon my ignorance, and correct me if I'm wrong, so a TIA, is that what, if we were to say the old days, would be a mini stroke? And the reason I want to bring that up, because I think so many people are familiar with the term, oh, that's a mini stroke. What in the world does that mean? So we just described TIA right now, but when the blood flow resumes and we're looking at not as much stoppage or damage, let's talk about that. And then Captain Peoples, I'm going to talk to you about time right after we're finished with this.
Very well.
So TIA, what is happening during a mini stroke, or what really is a TIA?
So the same as the ischemic stroke, there's a thrombus coming into the blood vessel, and it stops. And then somehow it resumes. Maybe the thrombus is not as big. And then, you know, all the symptoms start resolving.
Okay.
And so.
So I love that as a transition, Captain Peoples, when we're looking at, you got the call. Your crew gets the call. You don't know what the call, maybe you do know what the call is, but you have someone now, you're in their home, you're looking at them. And I know this sounds so simple for me to say, you're looking at them, but what are you looking at? And usually it's somebody else that calls in a stroke, usually,
Yes,
correct?
ma'am. That's correct.
So what is it that someone is describing to you, and what questions are they asking you? And I know this is also so big. What do you start doing immediately?
So great question again, Catherine. When we first arrive on scene, one of the main things we want to do is to do a quick assessment. And we're looking for facial droop. We're looking for arm drift. We're looking for slurred speech. A lot of times when we get on scene, our initial reaction is to take a quick look at everything that we see around us. So once we enter that set, because the family member will approach you and they'll say terms that are crude and rudimentary, but they'll say such thing as, hey, it looks like mom is having a bad day, her face is twisted, or dad looks like his face is melting. They'll also say things like, you know what, they're just looking funny, or they sound funny, or they're whistling funny. So once we start taking in our surroundings and our ambiance, then we start to focus on the patient himself. Because remember, we're getting quite a bit of information from our dispatchers. And so we're already knowing that time is of essence, time is essential. And we know already we're starting to see what is the most appropriate facility for this. Is it going to be a comprehensive stroke center, which can handle the most complex cases, or is it going to be a progressive stroke center? So we're also making the determination again as to get that lapse done, that assessment, that pre-hospital.
So you're in the home,
We're
and
in
at
the
that
home.
time figuring out, where do I take them? What is
Absolutely.
the best place to take them to right now?
Absolutely, and these things go very fast. They go very fast, but we have, like I said, pre-established protocols and procedures in place that allows that quick assessment to take place. Once we come in and we find out that they have a positive lapse, we're already on the phone calling in the appropriate hospital for a possible code brain. Code brain is our policies and procedures that alert hospitals, ER physicians, the team here, that we could be coming in for a possible cold brain. Because we know, even though we're still with the patient, we're loading and go, getting the vital signs, getting the glucose, ruling out all of those other possibilities that you've heard some of my colleagues speak about. But in the back of our mind, we know that there's a time limit for the streptokinase or the tenecteplase. We know that there's a CT that needs to be done. So all of these things are happening in a very rapid sequence. So our team is very efficient at doing these assessments. And then we get ready to take it to the specialist to call in what we see. So it happens very fast. Like I said, some of the more archaic terms are not suitable for the show, but sometimes you'll get on scene and they'll just say, Mom really looks bad.
Yeah, just messed up.
Messed
She
up.
looks messed up, right.
But we've also seen it where, they're just so slight and subtle to where the medical terminology will be ptosis with the eyelid droop, but they'll just have very minimum, very minimum. So there's a lot of conditions that we should be looking at, but the Los Angeles Pre-Hospital Stroke Screen is what we do to recognize and parse those kind of patients out.
So this is where I would like to say to the audience, and I'm looking at you specifically, and also that you're a fine young man.
It's far too kind.
But it matters. The 911 phone
Yes.
call matters.
That
This is not a
matters.
time, because we were talking about Be Fast, and we'll talk about that specifically in a moment. But 911 means that you guys are on the spot.
Absolutely.
That time that you're talking about is crucial.
Very
and when we
crucial.
say time, we're talking between 20 minutes and an hour could mean all the difference.
Time is of the essence.
Absolutely, and I'd love for you to hammer that home, because 911, people are like, should I call 911? She just looks a little droopy, what do I do?
Don't hesitate.
Okay.
Don't hesitate, and you have the program in the right direction. You should never hesitate. If there's any doubt, call 911. Let us get there and do our job. Let us get there, do the quick assessment. Again, we're gathering information from the time that phone call comes in. When dispatch calls that in, they're already relaying it to the crews. By the time it's relayed to the crews, we're already en route. By the time you are en route, you're still on the phone with the dispatcher. Our crews are there usually within about 5 to 7 minutes.
That's so
usually.
impressive.
It is very impressive.
It is impressive.
And it's gotten even more impressive now that we have a partnership with University Medical Center with their mobile stroke unit, because that stroke unit is also staffed by highly trained fire department members who can recognize specifically these types of strokes that range from, TIAs, ischemic, hemorrhagic. And when we do our assessment, we report not only the lapse, but we also will report to the receiving facility the LAM score, which they will use to rule out maybe a possible large vessel occlusion. But I'll let my colleagues dialogue on
That's a perfect segue to Dr. Eze. And let's say that we kind of are looking at now with what information's been given, that it's an ischemic stroke, which means there is a blockage. And there are several ways to treat that. There is, you go in, you do imaging right away. There are some medications you can do, try to get the blood flow going, and then there are some procedures to do. So I'd like to kind of take it from ischemic right now, because then we're going to do hemorrhagic in just a little bit. So let's just say an ischemic stroke is coming in to the hospital. What is it that now the hospital starts doing? I know that you're the hospitalist, but we're just gonna bounce this back a little bit back and forth.
So this patient shows up in the hospital, in the ER. One of the first things that the ER doctor asks is the time. So we need to know the time. Time is of essence. There are medications that are available for patients who come into the ER in a timely manner. Okay. So if
IV TPA, I just want to repeat that because I think that's super important. So IV TPA, so through an IV, okay.
The clot busting medication within 3 hours. You also have the extended window, 4.5 hours. But you don't want to wait, because the more time you wait at home, the more brain cells are dying. You don't tell yourself, oh, 4.5 hours, let me check it out a little bit. You want to get there, because if the blood vessel is open on time, then you're likely going to be left with as little deficit as possible. So the patient comes into the ER unit. We do the NIH stroke scale. That tells us, in a nutshell, what's affected, how big of a stroke it is, what blood vessel are we looking to that may be affected. Basically, is it a small blood vessel sometimes, or big? We may not know. We may have a fair idea by looking at the NIH stroke scale. As we're getting that, we're drawing some labs, because we're thinking of, because it's often very difficult for you to tell an ischemic from a hemorrhagic stroke.
Right, exactly.
And if it's a hemorrhagic stroke, the patient would not benefit from being given IV TPA. So most ERs are trying to reduce the time it takes to get to the CT scanner, to get the CT scan. The CT scan is read almost instantaneously. We get the word, it's a hemorrhagic stroke, no IV TPA, or it's not a hemorrhagic stroke, go ahead. Or it's an ischemic stroke, but we're already seeing the stroke on the CT scan. So the brain is probably, this patient might not be a good candidate for IV TPA. But let's say the brain looks good. Then the neurologist says, okay, gives the word to give IV TPA. IV TPA is given. While all this is going on, we're also taking another scan called the CTA. This looks at the blood vessels. Remember, it might be a small blood vessel, or it might be a big blood vessel. Now, if it's a big blood vessel, which we call the large vessel occlusion, then more rooms for more therapy is open. In all comprehensive stroke centers, you have a neurointerventional person on call. The neurointerventional specialist is a neurologist who is also trained to go in and pull out a clot in a big blood vessel. They are also, by training, either stroke specialists or intensivists.
So I'm going to stop you there, because I'm going to ask, when we've got a neural interventionist that's there, how are they going in to take that blood clot out? And I think that's super important too, because if you're looking at a large artery versus a small blood vessel, this is where you're trying to depend. A small blood vessel, you're trying to depend on the anti-blood clotting medication. So we're looking at now, that's not working. We're finding we're now in the hospital for a good half hour, let's say. That's 30 whole minutes. And the medication's not working. So now we have an interventional neurologist.
So
where do they go in to do physiologically, if you can explain what it is that they're doing, how they're getting that clot out?
If it's a large vessel stroke, okay, from the NIH stroke scale or the CT angiogram, they see the blood vessel. The stroke, the interventional team is already on the standby, because they got that
from the
call
EMS
from
Mr.
Captain Peebles. From
exactly.
Captain Peebles. They got that call, so they're already waiting. They take the patient to the interventional unit, and they go through the big blood vessels that can be accessed peripherally. They could either go through the radial artery, the artery in the, on the wrist, or they could go through the big groin femoral artery, go up there with their dye, look for the clot, and oftentimes they have different techniques for trying to get out those clots. Sometimes they try to aspirate, they aspirate, and they aspirate, and they get out the clot. Or sometimes they go
So
in.
explain what aspiration is. So let's just think the people at home don't understand what aspiration is or ischemic. So when you say aspirate, we're trying to little by little break the clot up. If you can describe it in
You're
that
trying to use
terminology.
some little vacuum
Excellent.
pull to pull the clot out
There we
with
go.
some
Okay.
pressure, pulling the clot out with, that's aspirating.
Okay.
Pulling with some pressure. Then they could also use retrievers, kind of like hooks, to go in. They go up, they go in and pull the clots down and out, down
Okay.
and out. And then they push their dye and look at the blood vessel, and oftentimes you would see the blood vessels open up again, and you have a lot of clapping in the...
Right. Everybody's all happy. We got the
everyone is
aspirations
happy.
out. Part of the clot's going
Yes,
out
the
now.
clot is out.
Beautiful.
So that's what they do.
Okay, so Dr. Alvarez, so almost actually just the opposite situation. Now we're going to look at a hemorrhagic stroke. So if we think hemorrhagic, just think of hemorrhaging. When someone hemorrhages, they're bleeding. So now we've got a brain bleed going on. So now it's this type of stroke. And as a hospitalist again, Captain Peoples and all of his guys have been communicating with you. You kind of know it's a hemorrhagic stroke. You're going to do all the imaging. How does one treat that? So ischemic, I can see that because you're looking at trying to get the clot, you're loosening the clot, but now we've got a bleed going on. How does one stop a bleed? Do you, number one, try to do medications first, then is there a procedure? And so I know it's almost the exact opposite of the previous question, but have at it, have a good time.
So it will depend on the size of the bleeding, and thank God we don't need an MRI sometimes like we do with ischemic stroke. With the CT will be enough, and that will depend how big is the hemorrhage. If it's going to the other half of the brain, or it's small. So depending on that, we have diverse actions that we go from. So if it's too big and it's compressing really the brain, the other half, or the same half, then you call the neurosurgeon, because we need to open that up to release the pressure. Because then
So that concern is more about now we've got so much fluid on the brain or by the brain that we're looking at damaging the brain because there's so much fluid in there, meaning blood in there.
Correct.
Okay.
Correct.
And the reason I'm asking this too is there a certain point where you have to go into the skull and relieve the pressure from opening up the skull? So talk about that, because I know it's gross and disgusting, but it's real and it matters.
Yes.
So talk about how that pressure can be relieved in all of the easy ways, but also going into the dramatic ways of having that happen.
So it will depend on other comorbidities that the patient may have, where the neurosurgeon may say it's too risky, and I don't think we should do it, just because of the multiple medical problems, even a bleeding problem the patient may have. So in that case, we may use some medications to try and minimize the bleeding, especially if it's profuse. But then our job as a hospital is stop there, and then the neurosurgeon takes over, and we open that up. We call that craniotomy. And the other thing here that we haven't mentioned is blood pressure. Like patients with ischemic strokes will come in with high blood pressure, so we have some allowance in there. With the hemorrhagic one, we have to be more aggressive on controlling the blood pressure, because it's the one probably causing more bleeding. And so we have to see those things too. Either we're going to treat or not. In that case, with the hemorrhagic, we're more aggressive. So we have some parameters there to see if we're going to stop a drip with a medication that will lower the blood pressure or not.
Okay.
And so in terms of like really having a medication for that, it's not the same as with the ischemic stroke. So
right, that's more like getting in there and getting the pressure released.
And then, like Dr. Eze said, we have this new, well, it's not new, but the interventional neurologist will come and also coil if this is an aneurysm, and same procedure as the ischemic stroke. We'll take the patient in the cath lab and we'll probably coil the aneurysm. So, or also,
So I'm gonna So coil the aneurysm. So in my head, I'm thinking, okay, so you're taking whatever that vessel is that's had the bust, the bleed, so to speak, and you're coiling it. Are you cauterizing it? Like, what are you physiologically doing when you coil that? And maybe I'm reading it wrong with how you're saying it.
No, well, that's the way the procedure is called because of
Okay.
the name. But yeah, I'm not sure what they exactly do. I don't know if Dr. Eze will have a better idea. But
Well, yeah, it makes sense. Somehow you're just trying to cut off the extra bleeding from there. Captain Peoples, what I like to do, and I haven't cued you in on this, but we all saw on my paperwork from past shows, Be Fast. And so I'm thinking to myself right now that let's say that I've been noticing that my mother's been having a problem for like the last 2 or now 3 hours. So we're going into time now.
Yes, ma'am.
So when we were talking about Be Fast, we're going in time like, okay, I'm finally going to call 911 because things just aren't right. Is there a certain time, and I think, Dr. Eze, you were talking about there's 3 hours, 4 hours, but let's not wait that long. When is it that this really is danger point, that we've waited too long and now we're really going to have an issue later with rehab, or the brain's been cut off from blood too long? If there's a way to give me a scope of time, like 3 hours to 6 hours, 1 hour to 4 hours, and the reason I'm saying this too is we want people to be on it
Right.
when something's off. Is there an approximate time frame you can give to that?
So that's a good question, and let me try to address it best I can. I'd have to go back to my colleague here to the right.
Mm-hmm.
So our main objective is to identify that stroke victim and get them transported as quickly as possible. So like I said, we're usually there on scene within about 5 to 8 minutes.
From the phone call.
From the phone call.
And that's
So-
and the reason I'm asking this is that I just know myself too. I'm like, they're going to be fine. So let's just say 3 hours have passed.
Right. So that's a good question. When they say time has passed, there's things like wake-up stroke, but no matter what type of stroke, when we first assess, we know that there's a time window for our other colleagues, 4.5 or
see.
3.
Okay.
Our goal and objective from a pre-hospital standpoint is to identify that patient or that individual in a very rapid, concise manner, so that we can meet the benchmarks and the metrics for the hospitals, for those comprehensive stroke centers. Again, when we look at the question that you posed, we have paired with a mobile stroke unit in which we will respond on scene once we have a positive lapse. We have a partnership again with UMC, the mobile stroke unit, where we will bring those resources and these types of colleagues that surround me at the table straight to the patient. So once we get on scene and we recognize that there's a positive lapse, we automatically call for the mobile stroke unit.
Gotcha.
So as the mobile stroke unit is arriving, and they usually get there, their times are very, very fascinating actually, but usually they're within 8 to 10 minutes also.
Okay.
So we have already began to work the patient up, such as I started the IV, we've done the assessment, so we're starting to do that initial pre-hospital stroke scale. We start documenting it. This helps with the continuity of care, so by the time the mobile stroke unit is on scene, they're going to arrive with the CT scan.
Right.
They're going to have the neurologist or the teleneurointerventionist
So
on
they'll
board.
know how far into it you are at
Absolutely.
that point. Okay.
And so they'll get there, and then that transfer of care will happen. The teleneurologist will either repeat the Los Angeles pre-hospital stroke scale, or they'll automatically go straight for a CT scan, but they are immediately transferred over to our colleagues who are present with me now, but we bring the care to them.
Right.
So I do want to opine a tad bit on those wake-up strokes, because a lot of the things that we talked about are very sentinel, such as the drooping eyelid, slurred
So when you
speech.
say wake-up strokes, literally they wake up and they're feeling...
Exactly. So
Okay.
your original scenario posed to me was like you wait about 3 hours. You weren't
Right.
sure. You were kind of wondering. And that reminds me of training and teaching that they talk in wake-up stroke, because much like our colleague alluded to, you can have a migraine. There's different causes, Bell's palsy. But the flip side of it is you have to be in tune with what's normal for mom or dad. So again, time is of the essence. If you have any doubt, you should be calling. So from the first onset that they're saying, well, you know what, mom's kind of slouched to the left today, and normally she's not like that. Or, you know what, Dad he's really got that limp shoulder going on, and that's not normal. The other thing is what's very important that I know my colleagues here will definitely ask when I get to the ER is, when was the last seen normal? When's the last seen normal?
That's the big question.
So when you pose a question on the time frame, it's very hard to truly box that question in because things are so dynamic. But what we do know is that we are gathering that information, making that assessment, notifying early on, cold brain, en route, whether we transport it to our colleagues or whether we activate the mobile stroke unit. So we want to identify that stroke in a rapid manner.
Right.
And the public can help us by, again, being very alert and attentive to what's normal for mom and dad.
Right.
What's
and
normal
don't be
for you?
afraid to call 911.
No,
I
don't
think
be
that's
afraid.
a thing too. It's like, well, it's going to cost money. You know, it matters tremendously.
Time is of the essence.
Time is absolutely of the essence. Dr. Eze, I'd like to go back to what we talked about a little bit earlier when you were saying that about a fourth of the people that are having strokes have had some kind of an issue and or stroke in the past. That is fascinating to me because that's a large number. So if there is someone that has and knows that they've had a TIA, and I'm looking at what are some of the symptoms and or risk factors for people having stroke. So one of them is you've had a previous stroke. But let's expand on that a little bit on having a mini stroke, and then might that lead to something bigger in the future, et cetera. What are some of the questions that you're asked on that?
So transient ischemic attacks, or TIAs, which colloquially are known as mini strokes, are very important because that serves as one opportunity that we have to prevent a patient from having a stroke. Like my colleague, Dr. Alvarez said, ischemic strokes are caused by blockage. So you have blockage. In the case of a TIA, for whatever reason, the blood vessel opens up. Voila, the patient is good. They had right arm weakness, and now they don't. Now, we still want them to come to the hospital because this is our opportunity to find out why they had a stroke and to intervene and find out why they had a TIA, which is the same reason they're probably going to have a stroke if left uncatered for, and then to intervene to prevent them from having a stroke. Now, what are the common reasons for having a TIA or a stroke? There are factors that you have you can modify, modifiable factors, and there are factors that are not modifiable. So not modifiable factors, it's more common to have a stroke the older you are because the blood vessels are more craggly. The blood vessels don't look as good as they used to be when you were 20, so it's more likely that these blood vessels could get blocked, okay? You can't do anything about your age. But what are the things we can do stuff about? The risk factors for stroke that are modifiable include high blood pressure. Dr. Alvarez talked about high blood pressure as a very common, very important risk factor for both ischemic and hemorrhagic strokes. So we want to know if some patients come into the hospital with a TIA or a stroke, and that's the first time they're finding out that they have high blood pressure.
Right.
What other risk factors? We talk about diabetes mellitus. Is the patient diabetic? A lot of people don't know. They don't know what they haven't been to a doctor in years, so they don't know if they're diabetic or not. We talk about hypercholesterolemia. Is the cholesterol high? We also, while the patient is in the hospital, as part of the testing that is done, we've talked about looking at the blood vessels in the head and neck. Could either be done with a quick ultrasound or a carotid ultrasound. It's also done with CT angiogram, looking at those blood vessels. Is there a blood vessel that is almost occluded? Because that would be a chance for us to send the patient to a cardiothoracic surgeon who can open up that blood vessel before it occludes entirely. Okay? So it's also, the opportunity also arises while in the hospital to do an echocardiogram, which is an ultrasound of the heart. Is the heart looking good? Is there a blood clot sitting in the heart? Because if there is a blood clot sitting in the heart that is throwing off little blood clots that may cause stroke, then we should work on that blood clot and make sure the patient is on a blood thinner and anticoagulant. So we also, while the patient is in the hospital, put the patient on a heart rhythm monitor. One of the most common causes, especially in elderly individuals,
I'm glad you're going to bring this up,
of a stroke is what we call atrial fibrillation.
Exactly.
And it's not something that the patient would know they had.
Right.
They have a TIA, they come in, we put them on telemetry for 24 hours.
Describe what AFib is, just for the audience. Describe what that is.
AFib is an irregular heartbeat, okay? So when the heart is beating very irregularly, then the blood doesn't flow so well. And because the blood doesn't flow so well, you can have blood clots sticking on the sides of the heart. And this blood clots, when the heart contracts, can get off, go to the brain and cause a stroke. So atrial fibrillation is something we're typically very worried about, especially in older individuals who have had a stroke or something that looks like a large vessel occlusion type of stroke. So in the hospital, we put on, we do an EKG, we put on a telemetry monitor to see if we see atrial fibrillation. Okay, we don't see the atrial fibrillation while they're in the hospital. We get in the cardiologist involved. Hey, cardiologist, can you see this person? Can you take a look to see if this patient could have atrial fibrillation? Oftentimes, we link the patient up to a cardiologist while in the hospital. The patient goes out of the hospital on aspirin and Plavix just to keep the blood flowing while they go to the cardiologist. And the cardiologist oftentimes would give them a loop recorder, something they can have on them for 30 days looking for that sometimes elusive atrial fibrillation rhythm. So all this is geared towards making sure that we prevent what could possibly cause a bigger stroke. So TIAs, though they're called mini strokes and often overlooked by patients, are actually even more important,
super important to bring
than
up.
the
Right.
strokes.
That makes sense. That makes perfect sense. And I know that there's, and not that one is more dangerous than the other, but if you're looking at a blockage stroke, meaning a blood clot stroke, which is ischemic, versus a hemorrhagic stroke, which is again a bleeding stroke, is there one that will cause more damage in the future than the other? And the reason I'm bringing this up is that we're starting to get into the show now. I want to talk a little bit about what brain damage there is and how people can start rehabbing if there has been a prolapsed amount of time and we're in trouble now. And you're the hospitalist, and I don't know if neither one is good, and I get it, but is there one that can cause more damage than the other?
It's like Dr. Eze mentioned, it depends on the vessel, you know, if it was a large or small, how much of a time we let, you know, unattended the stroke. And so it comes to various things. Also, what other comorbidities? Maybe the patient wasn't walking anymore. Maybe the patient had dementia and won't remember and won't talk again. So when we activate also the stroke, in the protocol that we have various ancillary services, and speech will come the same day, depending on the time that the patient arrived. But speech, occupational, physical therapy, like Dr. Eze said, a cardiologist, obviously the neurologist too. So it will depend on how fast we move. It will depend the size. It will depend on what other medical problems the patient has. So the age.
Right, the age, that makes a big difference too. I'm going to throw this question out to whomever would like to take it, because I know that they're, you know, a comprehensive stroke center, and you were talking about that, Captain Peoples, earlier. I'm going to keep calling you doctor because it just comes out of my mouth, sorry. But there's also the idea of what's on the horizon as far as treatments go. We've talked about this, and maybe there's not something specifically that's coming up, but I think to myself as emergency response vehicles, and I think, man, there's a new piece of equipment in there every 6 months or every year, and maybe we can kind of start with that, because I've been lucky to go inside one of these units, and I'm thinking this is a hospital on wheels. I mean, you've got almost everything in there. So if you can describe what is in an emergency response vehicle, and what maybe you, as Captain Peoples, who's been doing this for quite some time, are excited about, you know what, next year we might be getting an A, B, and C that maybe Chicago has or New York City has, et cetera. If you can take that question and expand it any way you'd like.
Sure, I'd be delighted. One of the things I think is the most cutting edge and the most, one of the greatest accomplishments that the city of El Paso, along with the University Medical Center and the El Paso Fire Department, is that we have been able to implement a mobile stroke unit. And there's 21 mobile stroke units throughout the country. Texas.
21 throughout the country?
21 throughout the country.
And we have one here?
We have one here.
How
As a matter
nice
of fact,
is that?
Houston was the first.
Okay.
So there's 2 in Texas, and Houston is one, and El Paso is the second. So that's been one of the greatest accomplishments, I think, from the pre-hospital emergency setting. Again, with my colleagues here at the panel, we were actually able to bring the CT, the teleneurologist, this team of interdisciplinary professionals, acute care nurses, CT techs, we bring that straight to the patient. So when we talk about time, it is very crucial that you're going to always need comprehensive stroke centers. There's no doubt about it. But as time moves on and we continue to advance the care for stroke and recognition of stroke, I really do think that pre-hospital is where it's going to be where we really make that difference, because we're able to bring those resources there. So typically, even as fast as we are, by the time we alert the cold brain, there's still some time. You know, my colleagues alluded to that. You still got to go through the ED, you got to do that assessment, you got to get the labs, everything is going. But in the pre-hospital setting, we're able to make that assessment, bring those resources to the patient. So that window, that time of opportunity, you know, that is so crucial, so prudent, we're able to intervene right then and there. So they go from their living room to the CT scan in the field, and we're able to start to connect the plays. We're able to initiate many of the therapies and treatments are there. We've got, we're usually fortunate either with a resident on board or a specialist here who can actually tell us, hey, you know what, we're gonna have you titrate the blood pressure, or you have the teleneurologist who is gonna say, you know what, this may be an opportunity for a coiling, which you referred to. And so if you look at that, we don't have to go code 3 now, because there's things that have already been done. Right, there's things that have already been done. So that care is already established, it's already ongoing, and that provides the in-hospital setting to be a little bit more aggressive with the rehabilitation part that my colleagues have alluded to throughout the quorum. You know, so.
And that's, again, where time is so of the essence. And it's very exciting to me every time I learn about what's in these vehicles. It's fascinating to me, honestly. We are at about, yes,
I'm sorry, it's a 16-slice CT scan. That's
a 16-slice CT scan in a vehicle, on wheels,
driving. On wheels, pretty novel for an EMS outside agency. So that's where I see the future of stroke care going, and it's amazing. And
pretty soon we'll be able to have that on our phone.
Absolutely.
We talk about that a lot. It's
Absolutely.
like the Star Trek people and bones.
Absolutely.
You know?
Absolutely.
What I'd like to do is we're about 10 minutes out before the show ending, and I know it goes super quickly. Dr. Eze, I'd like to start with you. If there is something that we have not yet discussed this evening, but on your way over here, or when they said, hey, you got to go do this medical show, is there anything that we have not talked about yet that you would like to bring up before we start closing the program?
There isn't anything we haven't talked about yet, but I just want to emphasize that time is brain. I see a lot of patients in clinic who could have made it to the hospital, like they knew when the symptoms started and they waited and waited and waited, and now they have a deficit. Okay, stroke is the leading cause of disability. You don't want to have, and you have that disability. It's not something that you can cure. You can rehab, but it's probably never going to go back to what it used to be before. So at the point you have the symptom, pick up your phone, call emergency medical services to get you to the hospital. There are some, we talked about 3 hours, we talked about 4.5 hours, but there are also 8-hour and 12-hour windows for some of the large vessel occlusions or some of the wake-up strokes. So, okay, you could say, okay, mom has been out for 4.5 hours. I don't know. Get them to the hospital. The neurointerventionalist, if it's a large vessel stroke, can still go in and pull out the clot for what it's worth.
You know, it's interesting to say wake-up strokes, because that could mean anywhere they went to bed at midnight and now it's 8 in the morning. It could be anywhere in that time frame. So I love that you brought that up. And I also like that you said, not like that you said it, but stroke is the leading cause of disability. Not that it's preventable, but if you're on it and your timing is better, and if you're not like, well, should I call 911 or not, it could be lesser of a cause of disability. So I'm super happy that you talked about that. Captain Peebles, is there anything that we haven't spoken about yet that you'd like to get across? This is like the the hour that you're like, oh, let's go, let's go, let's go. What do you want to say? And it's hard, but at the same time, sometimes you're like, oh, I didn't bring up this and that and the other. So is there anything that you'd like to bring up that we haven't yet?
I really want to just echo the same sentiments that has been the common theme throughout the show is time is of essence, okay? Recognizing when was the last seen normal is essential, it's critical.
And normal, I think that's such a big word. And if you can describe that again, if someone's just looking, and I know you said crude words, you said that earlier people will describe it crudely, but if you just don't look right.
Right, and that's a good point. And this is why, like I said, the last seen normal is essential, it's crucial, but more importantly, knowing what is abnormal, in other words, knowing what's odd, what's wrong, because on many of the examples that we have provided, sometimes it may not be as overt. You know, it may not be as startling as a facial droop or an arm drift or slurred speech. It could be anything from a flutter, you know, to just loss of vision on one side, you know. So it's what I would recommend to the audience is to recognize that time is essential and identifying when something is abnormal.
Right.
If it doesn't look right, call 911. Call 911.
So here's a difficult question, because usually, especially in the idea of strokes, there usually is a person that sees this happening in the other person.
Right.
So let's say now you're a person that lives alone, has lived alone, and you're just, I mean, what are you feeling? Like, you can see a stroke on someone else easier than you can feel what's happening in yourself, because you might not see your face drooping. You might just think, well, I'm slurring because I'm tired. Is there any advice there? Because I feel like, yeah, when we're looking at someone, fine, all these things, but now it's just me. I'm at home, I'm 61 years old, it's 10 at night, and I'm just feeling odd. Do I call an ambulance? Like, what do I do?
So great question. And the first thing is to, yes, call 911. But more importantly, I would have to say, focus in on what you can do for those modifiable risk factors, the non-modifiables and the modifiable risk factors that the doctor here has alluded to early in the program. There's very little you can do about age, but you can still watch your diet. She mentioned hyperlipidemia. You can change and have dietary and behavioral modifications. You know, control your hypertension. My colleague alluded to that earlier. So if you follow, you know, preventive practices, such as taking the medications that have been prescribed, that should kind of educate you and cue you in when you're by yourself. So what do I mean by that? So if I've been listening to the panel and my colleagues and I'm on a hypertensive medication and I was told that I had a history of AFib or that I'm susceptible to AFib, the instant that I even feel a flicker, I'm calling 911.
Because you kind of know this
Because I
about
know
yourself.
the symptoms. So when we focus on prevention, preparedness, and education, we're able to kind of self-assess ourselves. So yeah, you're right. We won't be able to see the facial group. I may not even feel it. But if I'm focused on prevention, preparedness, and education, and I've been listening to my colleagues, then I may be able to know, hey, these risk factors that are modifiable and non-modifiable, those are things I should be watching for. Anything abnormal,
That's why people
call
watch
911.
this program. So seriously, thank you for being here for that. It makes a difference. Know yourself. In almost every program we do, just kind of know what's normal and what's not.
Absolutely.
Dr. Alvarez, you've been waiting for this moment. Anything that we haven't discussed yet that you'd like to get across?
Well, I have a few minutes.
There you go.
No, I'm just kidding. I would say probably, I was just discussing with Juan here, that what is one thing that I can advise people to do or not to do at home when they are feeling that they're having a stroke. We would say, you know, take an aspirin. And I would say don't until, it's better to call EMS and get them assessed, and maybe they can judge better if you are having an ischemic or a hemorrhagic, because, you know, it may be contraindicated. So I would say just call. Just call.
Just call. Make sure that phone call is made. I know that we're running out of time, but I do want to get this out here for anyone who is watching who has had a stroke in the past or just wants to know a little bit more about it. The city of El Paso is conducting a stroke walk on Sunday. And the nice thing is that Sunday it's Scenic Drive. It's going to be on the west side entrance. Scenic Drive is closed anyway on Sundays because we like to get people out there walking. But this is a special Sunday to be able to do that. And again, it's going to be kind of neat. There's going to be information out there. There's going to be a lot of your guys out there, EMS people out there giving out information. And also there's going to be like a stroke survivors walk there. So that might be kind of a neat thing to be a part of. I wanted to, I almost want to throw out one more question because we have like 3 whole minutes, which is an eternity in TV. Oh, 2 whole minutes. Then I will say this. If you have questions about strokes, if you have questions about AFib, which is atrial fibrillation, and we talked a little bit about that, but we really didn't go into it. But I feel like that's something that we hear a lot about now with different commercials on different platforms, television. It's when your heartbeat is just off. It can race 1 minute and feel like it's thumping through another minute. We didn't talk a lot about that tonight, but there's information out there when it comes to that too. I know that this program is sponsored by Tenet, by Hospitals of Providence. You can also go to WebMD and look up those questions. If you want to see this program again, it might be kind of helpful because sometimes you miss something the first, the second, or third time around. So to watch this program again, you can go to kcostv.org or pbselpaso.org and just look for watch and look for the El Paso Physician. You can also go to the El Paso County Medical Society. And the nice thing on both of these platforms, you'll have all of the different programs from, my goodness, the last several years. And you can search the specific program that you're looking for. You can find that there. And also youtube.com, you can find El Paso Physician right now. If you're looking at it, you can find that El Paso Physician live, or you can go back and find this program again. So that's going to be super helpful. And again, Be Fast stands for, who am I putting on the spot?
Balance.
Balance.
Your eyes.
Eyes.
Your face.
Face. Arms.
Speaking.
And T is time.
And T is time. So Be Fast, that matters when it comes to stroke. I mean, you want to be super, super quick when you can get there. Again, I want to thank you so much for watching. This is the El Paso Physician. We've been doing this for 25 years. And again, Dr. Eze, Dr. Alvarez, and Captain Peebles, thank you so much for being here.
Thank you.
May is Stroke Awareness Month, and it matters. Again, we weren't talking about celebrating, but it's just about getting the information out. And if you have nothing going on Sunday, head up to Scenic Drive, take a walk, enjoy the sun. We are in El Paso after all. This is the El Paso Physician. I'm Catherine Berg. Good night.